So first, we're just going to discuss a little bit about how the gait cycle works and how the foot adapts to that, and how some things that happen in the foot drive what goes on to the gait cycle. Well, when somebody's walking and they've got a normal foot, what's going to be the position of the subtalar joint at heel contact?
You're going to be, I think, neutral or slightly, I forget exactly. Is it slightly evert?
So at heel contact, we consider the heel, we think of the heel to being inverted by a couple of degrees for normal. But normally people have a little bit of varus. So I think thinking of it as neutral is reasonable, thinking of it slightly inverted is okay. But subtalar joint neutral at heel contact. And then the leg on the left is now at 25% of stance phase. Joseph, what happens to the subtalar joint between heel contact and 25% of stance phase?
Goes through eversion.
So the subtalar joint pronates. Eversion is the frontal plane component. But when we're talking about motion of the subtalar mid-tarsal joint or the ankle, we should describe them as pronation.
We're pronating.
Right. And why do we pronate?
Because we're putting the foot, the foot's coming into contact, and we're putting more pressure on the forefoot.
So what drives the pronation though? Noreen, are you still here?
Yeah.
What drives the pronation between heel contact and 25% of stance phase?
Is it the rotation at the hip?
Well, it's the rotation of the entire leg. So
Right.
The whole leg is internally rotating. When does the internal rotation change? So what happens now between 25% and 50%?
It's locked in because your foot is in
So the one up there on the left is 50%. So from 25%, we were pronated at 25%, right? And at 50%, we're now back to neutral. So what happened to the leg between 25% and 50%? Is Josh still in there someplace?
Yeah, I'm here. If that's the case, then it's supinating.
So it supinates. So what drives this pronation during the first 25% and then supination back? Joseph said it was rotation of the hip.
maybe the body coming over the hip. So you're
The whole body. So what
Yeah, it's
really
momentum.
happens- So when does the toe come off of the other side?
once your body goes all over the axis at 180, like when you're parallel with the ground.
Yeah, but so if I'm walking, everything is, and I don't think I can stand up and show you because I don't think we have enough room. But when we're walking, we hit at heel contact, the leg is internally rotating. It continues to internally rotate until the toe comes off on the opposite side. And then everything rotates back in the other direction. So I'm not sure if you can see this, but I'm going to try without the microphone. Yeah, it's too small. I can't take the microphone with me. So what really happens is when I hit, everything is rotating in this direction with my right foot coming forward. And as I hit the ground, I continue rotating that way until my toe comes off the ground on the opposite side. And then when that toe comes off, everything starts rotating around in the opposite direction. Everything rotates that way. So at heel contact, I'm still internally rotating on the right side in this group. And I continue rotating that way until my toe comes off on the left, and then all the rotation turns and goes in the other direction. So now my right leg is externally rotating. Everything on my left side is internally rotating. And we go through that pattern, right leg, left leg, right leg, left leg. And all the foot's doing is adapting to that. So as I start externally rotating because the toe has come off on the left, I get back to neutral position. As I continue to externally rotate, and I get to 75% of stance, the heel comes off the ground at about 60 to 65, but by 75, the heel's off the ground, and I'm still supinating. So what the foot's doing during this time is it's acting like a shock absorber to absorb that internal rotation of the leg and turn it into motion of the subtalar mid-tarsal joint. So we have pronation and supination that's occurring, but it's only in response to the rotation of the leg. Don't think about the foot pronation and supination driving the internal and external rotation. Think about the whole body internally and externally rotating, and the foot is just responding to this. So this, like I said, it acts really more like a shock absorber. So if I'm in a supinated position, I look like this. I've absorbed external rotation. If I'm in a pronated position, it looks something like this, and I've absorbed internal rotation of the leg. So all it is a response to the rotation that's occurring. Does that make sense? So don't think about the foot driving the leg. Think about the rotation of the whole body and the leg driving what's going on in the foot. And all we're doing is adapting to that. So how about sagittal plane shock absorption? Anybody have some ideas on how we might absorb sagittal plane shock absorption? The subtalar and mid-tarsal joint absorb the transverse plane and turn it into frontal plane motion. Anybody? Joseph, what's a sagittal plane shock absorber?
Sagittal plane shock absorber.
Well, if we think about the subtalar mid-tarsal joint as being the transverse plane shock absorbers we just talked about.
Just the forefoot portion?
So
Or
the-
at the ankle, I mean,
So the ankle is one of them, ankle joint plantar flexion.
okay. And the
So the
knee,
way that works is if I hit heel first, that lengthens my leg. So now as I lower my forefoot to the floor, I absorb sagittal plane shock, right?
yeah.
So ankle joint plantar flexion absorbs ankle joint shock, or absorbs sagittal plane shock, and knee joint flexion absorbs it. As I'm going over the top, I'm flexing my knee to absorb that shock that's occurring or the pressure that would be occurring in the sagittal plane, vertical force. So if I have so we're going to talk about some individual conditions now and how they compensate. So if I have an equinus that's this severe, I can't get my heel down first. So I lose that sagittal plane shock absorber at heel contact. And something else takes place. What's my sagittal plane shock absorber going to be for this patient? Sonum, are you there somewhere?
Yes, I'm here.
So we can't get heel first contact. So what's absorbing shock in this situation?
Just at the forefoot and then the body carrying over.
Right, so now we've got, basically, we're going to have the gastroc absorbing shock. The heel's going to try to come down to the ground. This is akin to when somebody runs barefooted. If somebody runs barefooted, they don't hit heel first. Their shock absorption is ball the foot first, and then lower the heel to the ground. So instead of the anterior muscles taking the shock, the posterior muscle group is taking the shock. So if somebody has an equinus and they can't absorb that shock normally, we can help them out with a heel lift. So think about something simple. If I put a little heel lift under an orthotic, then they're going to be able to hit heel first and have our normal shock absorption that occurs in the sagittal plane. So that might be some way that we accommodate for that. Now, last time we talked about the motion of the ankle joint really being pronation and supination. So the axis of the ankle joint can be found by just putting your fingers at the tips of the malleoli. And so if I plantar flex the ankle by raising the heel, I really supinate the entire foot around the ankle joint axis. It's not really just plantar flexion, I supinate everything. That's important to remember because anytime we use a heel lift for somebody, remember you're supinating everything. You're not just allowing the heel to hit first, but you're supinating the entire foot around the ankle joint axis. So let's go through a little this. I'm going to run through these diagrams. I'm going to use these going forward now. So what I'm depicting here is that the forefoot and the heel, and we're going to use the position of the heel to sit in for pronation and supination. So at heel contact, the heel is somewhere near vertical. The forefoot has no load. Doesn't make any difference whether I've got forefoot valgus, forefoot varus, nothing going on. The forefoot doesn't drive anything at this point. The internal rotation of the leg is going to drive this. And in a normal foot, by the time I get to 25% of stance, now we've got subtalar joint pronation. That pronation is just absorbing the internal rotation of the leg. And at this point, what's going to happen to the rotation? It's going to start to move in the other direction. So now we're going to start externally rotating this leg because the toe came off on the other side. In normal situation, we get to neutral by about 50%. Now at this point, if we go back one slide, what's going to be the condition in the mid-tarsal joint at this point, Josh?
It would be unlocked.
Be unlocked because we just put some load in the forefoot. But for the mid-tarsal joint to be locked, the forefoot would have to be verted further than perpendicular to the heel. Because as we pronate the subtalar joint, we increase the amount of motion that's available at the mid-tarsal joint. So we have an unstable mid-tarsal joint of 25%. So Josh, what happens by the time we get to 50%?
By that point, you're starting to resupinate and then you're locking.
Right, so now we've resupinated back to a neutral position in a normal foot. The mid-tarsal joint is now stable. So I can no longer push up on the outside part of this without moving the rear foot. So now we've got a normal mid-tarsal joint stability. The first ray is now starting to take some load. And then as we move on to 75%, what happens? The subtalar joint supinates. That reduces the amount of motion that's available to the mid-tarsal joint. So the mid-tarsal joint stays stable, but the first ray has to plantar flex in order to reach the ground. And that's not obvious on this one cross section. This is a little better depiction of what's going on as the heel comes off the ground.
Oh, shit.
Somebody have a question? All of the metatarsals invert as we invert the foot. So this inverted relationship of all the lesser metatarsals happens as we supinate the foot because everything inverts along with supination. So why isn't the first metatarsal inverted? Noreen,
Not sure.
does somebody want to help her out? So as I said, all the metatarsals invert. The whole midfoot inverts, all the metatarsals invert along with the supination. Why does the first ray not invert with that?
Is it because it has its own axis of motion?
Has its own axis of motion, and as it plantar flexes, along with plantar flexion occurs eversion. So this is a better depiction of what's really going on. So as we raise the heel off the ground and we're supinating the subtalar mid-tarsal joint, all these lesser metatarsal heads are inverting, and the first metatarsal head is being driven down to reach the ground. And what drives this first metatarsal down during this phase of gait? So we were just talking about what's going on at the first ray now. So as we're lifting the heel off the ground, all the metatarsals are inverted. The first ray is everted a little bit because it's plantar flexing to get back down to the ground. What is driving this plantar flexion of the first ray? Akil?
The first ray is being plantar flexed, like excessively.
Yeah, so what's driving the plantar flexion of the first ray now? What's making the...
Peroneus longus.
So the peroneus longus pulls the midfoot together and does have a little bit of plantar flexury force on the first ray. So as all the metatarsals move away from it, it can pull it down a little bit. But the primary thing that drives this once the heel gets off the ground is the plantar aponeurosis and the dorsiflexion of the hallux. So think of the first ray as stabilizing, the peroneus longus is stabilizing the first ray against the ground. And then what really drives this continued plantar flexion is the dorsiflexion of the hallux. And how do we load all these metatarsals and keep all the metatarsals loaded when we've got them at an angle? Through something called the oblique toe brake. So the way this works is you roll up on the outside part of your foot in line with the oblique toe brake. The peroneus longus then pulls down a little bit on the first metatarsal. The hallux dorsiflexes and the plantar aponeurosis pushes the first metatarsal down further. So we're able to load all the metatarsals evenly because we have this oblique toe brake. So that when we were looking back here, and that really isn't a very good depiction of what's going on because we can't really see the angle of that oblique toe brake. So we don't have a situation like this where the second metatarsal never takes any pressure. We have a situation where all the metatarsals are equally loaded because of that oblique toe brake. So if we don't resupinate when we get the heel off the ground, where's all the load going to be? So if we leave a foot in this position like I had a minute ago, and I lift the heel off the ground when the foot's in this position, where does all the load go? Is there anybody I can't see that's awake?
The first MPJ.
Yeah, so where's the load going to be? If we have that situation now and we've lifted the heel off the ground, we're in a pronated position, where's all the load going to be?
Yeah, in the first ray.
So if I lift straight up, if I just pull the heel off the ground, where's all the load going to be?
The forefoot.
Like a metatarsal head. Can you envision that now? If I just pull the heel off the ground and bear weight that without resupinating, the load stays on the second metatarsal head. So the way this oblique toe brake functions is as the foot supinates, it allows us to load all the metatarsals. And then we pull the first ray down independently to load the first ray. So when we lift the heel off the ground, the oblique toe brake allows us to load the lesser metatarsals, and then we pull down and load the first metatarsal. Let's take some individual structural deformities. Let's start with rear foot varus. Who wants to give me a description of rear foot varus? Flavia, can you hear me? Arella, am I saying that correctly?
Yeah, close enough. It's when the calcaneus is in a varus position.
So there's little hanger-ons to go with that though, when the subtalar joint is in the neutral position and we're standing in base and angle of gait.
Okay.
And we can have rear foot varus that's because of tibial verum, like this line over here.
Mhm.
This diagram shows 5 degrees of tibial verum, another 5 degrees of subtalar varus. Subtalar varus would be an inverted position of the heel relative to the bisection of the leg. So that we can depict whether we're weight bearing or not. But overall, rear foot varus is the combined total of these things when we're standing in base and angle of gait.
Okay.
So how do we compensate for that if we have rear foot varus and we're walking? What's the method of compensation?
Forefoot valgus.
Well, forefoot valgus might be there, but forefoot valgus is a structural situation, right? So that's not a compensation for rear foot varus. We do see them together sometimes. But if we just stood this, if this person now all of a sudden got full weight, where would the foot go?
Doesn't it depend if it's rigid or not?
Yeah, let's assume we have adequate range of motion.
Then it would pronate.
So it would pronate till the heel is vertical or we run out of pronation. So I want you to think about rear foot varus as being whole foot varus. So the forefoot is perpendicular to the heel and the whole foot is in a varus position. So don't think about it just being the heel and then the forefoot's in valgus or somewhere else. Think about the whole foot being in varus. And so how do we compensate for that if we're going to make some kind of an adjustment to a shoe or an orthotic to keep that from pronating? Josh?
Would you plantar flex the first ray when you're trying to mold them to it if they are able to compensate?
So let's take a minute and talk about that. So when you're taking an impression of somebody, I think it's always a good idea to gently push down on the first metatarsal until you run out of range of motion of the first ray. I think that's a good position to be in. I used to consider the neutral position or the functional position of the first ray as being the center of its range of motion. But over the past several years, I've come to realize that it really makes more sense for the first ray to be in its plantar flex position for optimal function. So yeah, we do pull it down a little bit and that may reduce part of it. But we put a rear foot wedge on. So if I put a wedge under the whole foot, the foot isn't going to have to pronate, right? So if I took that rear foot varus that we had on the slide before and I put this wedge underneath there, we can stand up without pronating. If we put a rear foot varus post on there, that may help right at heel contact, but it's not going to when the forefoot hits the ground. If there's only a few degrees of rear foot varus, we don't worry about that too much. We grind this little corner off and we let the foot go to where it's going to go as the forefoot comes down to the floor. So this little grind off we put on there is to allow that little bit of pronation that needs to occur following heel contact when we're using a rear foot varus post. Now, if we have somebody that has 10 degrees of rear foot varus, we might have to have a rear foot post and we might have to have a little bit of forefoot post in the front to keep them from pronating all the way down to the ground. So it might be we need to have a combination of rear foot and forefoot posting, even though they've only got a rear foot varus deformity. Anybody have a question about that? So rear foot varus is pretty straightforward. Inverted posting is going to help us control that. Forefoot varus is even more straightforward than that. Somebody give me a definition of forefoot varus. So let's have a volunteer here. Sonam. Is Sonam still with us?
Yes. Um,
Give me a definition of 4-foot varus.
the medial column doesn't go down to the ground, so the forefoot is inverted compared to the rear foot.
Inverted when, give me the rest of the definition. Somebody help her with the rest of the definition. Somebody help her with the rest of the definition.
You're saying in comparison to the rear foot?
Okay, it's inverted relative to the rear foot when the subtalar joint is in its neutral position and the mid-tarsal joint is fully pronated and locked. If you don't have those two conditions, you can't really define it as 4-foot varus. So this is a diagram that Alan Whitney made for me long ago. This A would be what 4-foot varus looks like. So at heel contact, if we had a patient with 4-foot varus, it might look like this. Forefoot is inverted. Mid-tarsal joint is fully pronated and stable. And how do we compensate for that? What happened to get from A to B? Joseph.
The foot pronated to compensate.
Right, so the foot pronates to get down to this position. So what do we do to keep it from pronating?
We like are orthotic or we shim it so the foot gets locked in.
Right, so we put this little wedge under the forefoot so it doesn't have to do that. And a 4-foot varus wedge along with a little bit of arch support, and we can keep this from compensating. So this is, again, this is really pretty straightforward. 4-foot valgus becomes a little bit more complicated. I need somebody to give me a definition of 4-foot valgus with the same hanger-ons we use for 4-foot varus. Any volunteers? Akil.
The forefoot is everted relative to the rear foot, and while the heel is perpendicular to the ground and the S2J is locked. So the lateral column is lifted off the ground.
So you're close. So the forefoot is everted relative to the heel when the subtalar joint is neutral and the mid-tarsal joint is fully pronated and stable.
Okay.
So remember, you need to say subtalar joint neutral, not heel vertical, because we might have rear foot varus or something else going along with it.
Okay.
So this would be what I call total 4-foot valgus. So our 1 to 5 relationship is everted relative to the heel when the subtalar joint's neutral and the mid-tarsal joint is pronated. Plantar flex first ray is also 4-foot valgus. So we still have an everted position of the forefoot relative to the rear foot when the subtalar joint is neutral and the mid-tarsal joint is pronated. But the alignment of the forefoot looks a little bit different. So that's a structural subclassification of 4-foot valgus. Total 4-foot valgus, plantar flex first ray type 4-foot valgus. 70% of 4-foot variations are valgus. So about 45 years ago, I looked at 250 consecutive biomechanical evaluations that I did and found out that 70% of the 4-foot variation, either varus or valgus, was actually valgus. Now I was including both the plantar flex first ray and the total 4-foot valgus when I'm calling that 4-foot valgus, but 70% of them. And then we have a functional classification of 4-foot valgus. Both of these feet have 4-foot valgus. The functional classification would be rigid 4-foot valgus and flexible 4-foot valgus. And so the difference is How does a rigid, well, you tell me, what's the difference? How does a rigid forefoot valgus compensate when they stand down? This right foot is a rigid forefoot valgus.
Rear foot varus.
Well, what's the definition of rear foot varus?
So they just, are you saying they just supinate?
Right, so they supinate. So it isn't really rear foot varus. The rear foot is inverted, but it's because the subtalar joint supinated in order to get that forefoot down to the floor, right? So if I look at this patient with his foot off the ground, he's got a plantar flex first ray and a total forefoot valgus on both sides. But when he stands down, the right one is rigid, so he supinates in order to get his foot down to the floor. So the right one is rigid. How do we compensate for that? What do we need to do to keep him from supinating?
You can do a first ray cutout.
If it was all plantar flex first ray, you could. So basically, we need some kind of a valgus wedging, right? And we'd like that to fit the shape of the foot. So if we've got that, if we have that situation where it is plantar flex like that, when we make the orthotic, it should be shaped like that. And then when we put our forefoot valgus post on there and it's across at an angle like this, it's going to look like it's wide on the outside and narrow on the inside, but it's not necessarily going to have a straight edge across the top. So a forefoot valgus post doesn't have to look just like a wedge. It should look just like the front part of the foot, but the outer side of it is elevated. So let's walk through that forefoot, that rigid forefoot valgus. With normal on top with our little stick figure we're going to use, and rigid forefoot valgus on the bottom. At heel contact, that rigid forefoot valgus doesn't do anything to function. Normal on top, what happens at 25 by 25% of stance phase? Noreen? So when we're walking normally and we get to 25% of stance phase, what has happened to the foot?
Sorry, my mic was off. You're supinating.
Does this look like this is supinated?
Or, oh,
When we're walking, what happens between heel contact and 25%?
oh, you begin to pronate.
Right, so you start pronating right at heel contact. As soon as the foot hits the floor, it can no longer move with the leg. So that torque converter that we had a picture of before causes pronation. So normally we pronate and that allows the leg to internally rotate. So what happens with a rigid forefoot valgus between heel contact and forefoot contact? Forefoot's on the ground, what happens by 25%? Josh?
It would start, I mean, from that picture, it's starting to look like you're almost getting like ankle valgus because the ankle is like, or sorry, the leg is starting to internally rotate too much in order to like,
Well, so the one on top, the leg is internally rotated, right?
right.
Because the leg has to internally rotate for the subtalar joint to pronate, right?
Okay.
So if we have a rigid forefoot valgus, we can't do that. So if we have this rigid forefoot valgus, which is going to compensate through subtalar joint supination, what happens when the forefoot hits the floor? It causes the subtalar joint to supinate, right?
Yeah.
What's the leg trying to do? What's the leg trying to do now? Josh?
At that point, it's trying to externally rotate.
Right, it should be trying to internally rotate because we're still loading. We haven't gotten the foot off the ground on the opposite side. So at a time when the leg is trying to internally rotate and the foot should be compensating for that, that rigid forefoot valgus is driving the leg into external rotation. So it doesn't create an ankle valgus as much as it creates a lack of shock absorption. So we got a situation here where we can't absorb that transverse plane shock. Now that may cause some trouble at the ankle, it may cause trouble at the knee, but it's definitely going to cause trouble somewhere along the line because we can't have our normal transfer of force. So we're in an abnormal situation already at 25% of stance phase. At 50% of stance phase in a normal situation, we want the subtalar joint to be back to neutral so that the mid-tarsal joint can be now loaded and stable. So the mid-tarsal joint is locked here. So with a rigid forefoot valgus, the mid-tarsal joint has been stable since it hit the ground. So we might be over-supinating at this point, but we're certainly stable. And by the time we get to 75%, now the normal foot can lift the heel off the ground without the mid-tarsal joint pronating. The first ray gets pushed into plantar flexion. The rigid forefoot valgus has been ready for this from the minute it hit the ground. So our real problem with this rigid forefoot valgus comes at that 25% spot. Normal, we want pronation there. Rigid forefoot valgus, we get supination, which causes a shock to the system by not allowing the leg to internally rotate. And so we accommodate for that with a valgus wedge. So do we need an orthotic to go with this if we have rigid forefoot valgus? Flavia? Do we need an orthotic to go with this forefoot valgus wedge? How about Arella? Do we need the arch support to go along with this?
Yeah. So all the stress isn't in the arch?
We have, so how does this rigid forefoot valgus compensate?
By supinating?
Supinating. We're trying to stop the supination. So does this wedge stop the supination?
I guess. Don't you
Yeah,
think
'cause I
there's
mean,
still like stress within the arch of the joint there though?
well,
Like
not
not, okay.
on a rigid forefoot valgus because it's a very stable foot already. So that's all I need now is a little wedge under their insole. I might use an orthotic if I've got something else I need to attach to it. It might be convenient to use it with an orthotic so they can change it from shoe to shoe, but fit to the arch is not going to mean much of anything. The forefoot valgus wedge is what's going to be stopping this supination. Now that's different with non-rigid forefoot valgus. In that same study that I did 45 years ago, 70% of those forefoot valgus feet function non-rigidly. So how does non-rigid forefoot valgus function? Somebody want to give me a guess? Has anybody ever told you, described non-rigid forefoot valgus to you? So I don't know who's residents and who's students here, so I don't know who I should be picking on. Josh. How do we compensate non-rigid forefoot valgus?
So like flexible valgus, that's like the same thing as flexible valgus, right? So
Okay. So how does flexible forefoot valgus compensate?
with rear foot varus to some extent, like
Well, rear foot varus is not a compensation. Rear foot varus is a fixed structural deformity with the heel inverted when the subtalar joint's neutral and when base and ankle gait. So let's not use that as a method of compensation. Do you mean supination of the rear foot? Supination of the subtalar joint?
Yes.
So that's how rigid forefoot valgus compensated, right? Non-rigid doesn't compensate that way. Flexible forefoot valgus. Does flexible forefoot valgus foot look supinated when they stand?
No, they're looking.
That one on the left is his flexible forefoot valgus. How did that compensate? That left foot is pronated, right? You know, we've got medial and plantar displacement of the arch that we talked about last time that goes on with metatarsal joint pronation. The heel is everted as far as it'll go, even though that's only vertical. You know, that's fully pronated. So how did that change? What happened to the midfoot with that flexible forefoot valgus? So I'm going to give you a little the way I like to think about it, and I don't know that anybody knows exactly what the answer is. So I'm surprised somebody hasn't given you an explanation, but I'm not surprised that you weren't willing to spit it out. Really, what happens is the midfoot unwinds in the middle. So I have this valgus foot with a forefoot everted and the heel vertical. And the rigid one, it just tilts this way and comes down to the ground. And we get this supinated attitude like we have on his right foot. With a flexible forefoot valgus, there's motion available in the middle part of the foot so that the foot can unwind to get the forefoot down to the floor. Now that leaves us with an unstable position of the mid-tarsal joint. The mid-tarsal joint's only stable if it's up here. So if I could push up under here, it's stable, but if it's down here, now I'm going to have motion that's available in both directions. So I've got an unstable midfoot. So when I try to load the forefoot, I've got absolutely no stability in the middle of the foot. So that foot tends to function around over time over a pronated position. When I watch somebody walk in the hall, the foot that looks a little bit supinated one step, a little bit pronated the next step, and a little bit unstable the step after that, that's a non-rigid forefoot valgus function until proven otherwise. So when I watch somebody walk, I can identify most of the time who's going to be a non-rigid forefoot valgus before I even bother to examine the foot, just through the way it's compensated. Forefoot varus doesn't compensate that way, it always pronates. Rear foot varus doesn't compensate that way, it always pronates as far as it can to heel vertical. Rigid forefoot valgus doesn't compensate that way, it supinates to get the forefoot down to the floor. Non-rigid forefoot valgus is unstable in the middle of the foot. So if we run that through the little diagrams again, at heel contact, the non-rigid forefoot valgus is going to have no effect on anything. Forefoot's not on the ground. We're still at neutral subtalar joint. But when the forefoot comes down to the ground, it can unwind and wobbles all the way down rather than remember the rigid forefoot valgus drove us into supination. This one doesn't do that. So we're able to absorb the internal rotation that causes the foot to pronate, and the non-rigid forefoot valgus does absolutely nothing to resist that. It's like the normal foot, just lets it pronate. And it gets to that position, now it's pronated, and when it should be coming back to a neutral position by 50%, it can't. We've got a situation where we're unlocked in the middle. There's nothing to drive that back to neutral position. So we have a problem here with a pronated foot at 50%. We're now externally rotating that leg, but we're left with this situation where we've got to still have a pronated attitude when we're lifting the heel off the ground. Now, very often it'll do an abductory, there'll be what looks to be an abductory twist. There's like a supinatory motion as the foot comes off the ground, and it snaps into an inverted position at the heel. That does happen sometimes depending on how functional the first ray is. But we've got an unstable position at heel off. With rigid forefoot valgus, we had a jamming that occurred at forefoot contact. Now we've got an unstable position at heel off. And how are we going to compensate for that? What are we going to do with an orthotic to stabilize this non-rigid forefoot valgus?
First ray cut out.
Somebody likes first-ray cutouts. That voice sounded familiar. So a first-ray cutout wouldn't do us very much good if this is the position we're in. If I've got a total 4-foot valgus that's flexible, a first-ray cutout's not going to help. How am I going to stabilize the mid-tarsal joint? That's really what the problem is. It's the same 4-foot wedge. If that's a flexible 4-foot valgus we're looking at in that diagram now, and I put that wedge under there, now I've made a stable foot, right? Mid-tarsal joint is fully locked, pronated, fully pronated and stable in that position. Now with a rigid 4-foot valgus, that's all I need. But with a flexible 4-foot valgus, I've got to have something that fits exactly to the arch to go along with that. So I can't get away with just my valgus wedge without an arch support. So with the flexible 4-foot valgus, I do need to have that arch support that goes along with the 4-foot valgus wedge. Does that make sense? Who was volunteering the first-ray cutout all the time?
It was me, Arla.
So that, like I said, when I was looking at that diagram before and I was pointing out that one of the plantar flex first ray, that's important to incorporate, but you shouldn't just cut out the first ray, you should shape it exactly to the forepart of the foot. Now, if you have an extended 4-foot, then you can have a cutout on that. But this part of the orthotic should fit exactly to the shape of the foot. So when we, whoops.
I just feel like in my mind, the 4-foot is what's driving everything. So I thought if you just take that out of the equation, then the rest of the foot will fall into place in a neutral position. That was my thought.
Yeah, it doesn't necessarily happen. If we have a rigid plantar flex first ray and nothing else going on, that works. But if we have a total 4-foot valgus, like that, cutting out the first ray isn't going to do us any good. Now, if we have a plantar flex first ray and it's rigid, we cut out the first metatarsal, or we do a dorsiflexory osteotomy, the first metatarsal, either one, we fix the problem. But the total 4-foot valgus, that's not going to work. And if we have a flexible situation, then doing something to cut out the first ray is not going to help. We have to have support all the way across here and then down to the first ray. So think about it as the front part of the orthotic looks like this shape. And then we've got that little wedge on the front part of it. So I'm out of voice. I think I'm going to call an end here. Does anybody have any questions they want to discuss? Okay, I think that's it.
That
No
was great.
questions?
Thanks, Mike. Appreciate it.
Thank you.
Thank you.
Dr. Burns.
Talk to you all soon. All right. Have a good night.
Thank you for your time.